My name's Ben Bullen. I'm speaking today on neuropathic pain, particularly around assessment, investigations, and management. And I'm a podiatrist by background. My clinical background is largely in diabetes, but I will talk about neuropathic pain in the wider sense, because this is really important, certainly for assessment. Some of the investigations that are important to recognize why somebody might be experiencing neuropathic pain symptoms, and then I'll talk a little about the management in a diabetes and a podiatry context. So this first quote I like to start off with from the National Institute of Neurological Disorders and Stroke, because this is quite useful for clinicians, but also for patients. To understand neuropathy, like static on a telephone line, peripheral neuropathy distorts and sometimes interrupts messages between the brain and spinal cord and the rest of the body. So it's really important that when we talk about neuropathic pain, but it's not always understood as pain in the traditional sense. And that'll be important for this presentation and for your learning. I like to start off with a couple of definitions. Can't talk about neuropathic pain without talking about neuropathy. And as a podiatrist, as a lower limb specialist, we're talking about peripheral neuropathy here in the lower limbs. In the wider definition, peripheral neuropathy is any functional disturbance or pathological change in the peripheral nervous system. And there are over 100 types of peripheral neuropathy. So that can range from one nerve being affected, which we call a mononeuropathy, to several nerves being affected, which could be mononeuropathy multiplex. And in the case of diabetes, it's diffuse, it's bilateral, it is a polyneuropathy. So poly meaning multiple, neuro meaning nerves. So multiple nerves are affected and multiple nerve types are affected. And that has a role in what we see in terms of assessment, but also in terms of our investigations as well. So we need to be able to determine that not everyone with diabetes develops diabetic peripheral neuropathy, for example, and someone with diabetes could also still develop a mononeuropathy or maybe a mononeuropathy multiplex. And that's why I've put a definition of diabetic peripheral neuropathy up here nice and early in our presentation. So that is signs and symptoms peripheral nerve dysfunction in people with diabetes after all other possible causes have been excluded. So, yes, it's the most common complication of diabetes. And we know that in people over 60 years, about 50% will develop diabetic peripheral neuropathy. But actually, again, it's really important to be able to look at the other potential causes, of which there are many. And I'm going to do my best to simplify within this session. Now, what I can't do is I can't cover neurology from the very beginning. So it's important. It might be a good opportunity to pause if you're not so sure about your nerve anatomy in the lower limb, or you're not so sure about the dermatomes, which I have on the screen here. These are the areas of sensation on the foot that map to particular nerves. And so this is a really good time to go back, maybe have a look at an anatomy textbook, just to review your nerve anatomy, peripheral nerve anatomy particularly, and also the dermal distribution, which we call dermatomes. I've included this mnemonic because mnemonics are quite useful. As I mentioned, there are lots of causes of neuropathy, advanced age being one of them, and this mnemonic, DANG therapist, can be really quite useful. So the D in DANG is for diabetes mellitus because it's a very common cause of peripheral neuropathy, but it's far from the only one. Alcohol from the A is also fairly common because people that can develop alcoholic neuropathy. So we need to do some screening in terms of drinking alcohol over a long period of time and in excess. That can actually lead to some nutritional issues that really cause the neuropathy in people with alcohol dependence. And thinking of nutritional, which is the N in DANG, and I've put vitamin B12 in here, this is another really common cause of neuropathy. So a vitamin B12 deficiency is usually called pernicious anemia. So in terms of our investigations, it's important that we have a look at vitamin B12 levels because that might be a cause of neuropathy. And there could be other quite serious reasons, of course, as well, like the Guillain-Barré syndrome, which would need a full workup. Um, there could be toxins, and this is important when we're looking at somebody's occupational history, for example, if they're in a profession where they've been involved in working with lots of heavy metals like lead, but actually medications fall under this T for toxins as well. And there are some medications that are associated with neuropathy. For us, some of the antibiotics that we might use, like ciprofloxacin or metronidazole, are associated with neuropathy. So again, really useful to explore the person's full occupational, but also medical history, medication history. There are hematological causes. There are other endocrine causes. So a hypothyroid condition could cause neuropathy. There are rheumatological, and I've put um, some little prompts here for you, but RA is rheumatoid arthritis, SLE is systemic lupus erythematosus or vasculitis. Amyloid is a less common cause, but it could be caused by amyloid plaques. It could be caused by porphyria. If we go on to the I in therapist, infectious, I've put in syphilis, I've put in HIV, which are causes of neuropathy, less common than they once were, but still important in terms of your screening questions. Because somebody might have syphilis, they might have HIV that's causing the neuropathy. Sarcoid, you can have sarcoid tumors, or this T can sometimes be trauma as well. So if somebody's got a tumor that's affecting the nerve itself, or maybe the surrounding tissues that are compressing or actually destroying the nerves, that's certainly a cause of neuropathy, but also trauma. So if somebody has a common perineal nerve injury, that's really quite a common traumatic cause. And actually, this is one of the reasons why we like to explore potential trauma, but also back pain. If somebody's got lower back pain or has had back surgery, it may well be that their nerve pain is associated with a more proximal lesion or issue, or maybe an entrapment up in the lower back. So really important considerations here. Distal symmetrical polyneuropathy is the classic presentation in diabetes. So if somebody has pain or discomfort in one leg, or you've done some assessments and you've found that there's a loss of sensation in one foot or one leg, but not in the other, that is highly unlikely to be diabetes related, because diabetes peripheral neuropathy is distal. So we talk about a stocking and glove distribution. So a bit like putting on a stocking and then putting on a glove. The loss of sensation, the nerves are affected distally, so at the toes first, and that moves proximally up the leg and then up into the hands. The nerves in your legs are longer, so they're affected first. And again, if you've got a loss of sensation that's proximal and the toes aren't affected, that's less likely to be diabetes, because diabetes will classically affect the toes first, and then you might lose some sensation in the metatarsal head area and moves proximally. As I mentioned before, it's always bilateral. It's both sides, because the disease process is not happening in one limb versus the other, and it affects small and large nerve fibers. And so there are different assessments that are required in this setting. We can't forget the usual suspects. Now, these are important for people with diabetes, and I've included some diabetes statistics here, but actually for everyone, because cardiovascular disease can lead to neuropathy. So obesity, increased triglycerides, doubles the risk of neuropathy in a group with type 2 diabetes. Smoking increases that risk by 42%. If somebody has hypertension, that risk can increase from between 11 and 65%, And similarly, hypercholesterolemia increases that risk by about 2/3. So really important that we're considering the usual suspects here and thinking about cardioprotective medications. So quitting smoking, really important. For somebody with diabetes, we need to be thinking about optimal glycemic control because the risks for diabetes increase with longer diabetes duration, and if it's poorly controlled, glycemic control over a prolonged period of time, that in itself can increase the risk. So we need to be thinking about antihypertensives, anticoagulants, anti-cholesterolemia, hypercholesterolemia drugs as well in all populations and particularly in a diabetes setting. There are lots of questionnaires that can be useful here. I've included a few. There's the Leeds Assessment of Neuropathic Symptoms and Signs. There's Pain Detect. There's the Dollar Neuropathic 4, the DN4, which has the highest sensitivity and specificity and includes just 4 questions that include subjective and objective information that you could find useful. And there are lots of different tools out there to help you make sure you're asking the right questions. Some of the questions I've included here and using lay language. So the first thing is not just to say pain, because people might not experience pain. They might experience discomfort. So it might be a paresthesia. So a paresthesia is an abnormal, para meaning other, anesthesia is feeling. So it's a different feeling. So some of these we might prompt and say, could it be described as electric shocks or shooting pain? Is it a hot? Is it a burning pain? Is it prickling? Is it tingling? Is it pins and needles? These are paresthesias, but somebody might actually have what we call an allodynia. Allo is other, dynia is pain. So it's pain from some stimulus that would otherwise not normally be painful. So that could be something like just light touch, even putting on socks, for example. That might be exquisitely painful for somebody. So we need to be thinking about different symptoms, paresthesia, allodynia, but also we really need a scale, don't we? So a visual analog scale is a really great way of being able to determine 0 being no pain or discomfort, 10 being the worst imaginable pain or discomfort, where somebody is. So you could use a visual analog, or you could ask somebody on a scale of 0 to 10, where's your pain today? Or where is your pain at its worst? And the timing of the pain or discomfort is really important. What time of day or night is the pain or discomfort worse? Because with diabetes, the pain or discomfort is actually typically worse at nighttime. And the reason why we think it's worse at nighttime is our brains are doing lots and lots of processing during the day. There's lots and lots of stimulus that our brains are trying to filter. And when we don't have so much input, sometimes at night, that's when our brains might tune into these abnormal feelings from these nerves that, for a patient, you might talk about misfiring to help them understand that might be why they're getting pain worse at night. Sorry, I should have said there'll be some gory pictures, but not too many. Classically, sensory neuropathy, this is what we think about. There's a burn there, there's some injury to somebody cutting their own nails and not feeling their feet, so they've managed to take a piece of their toe away. If somebody's had a significant burn, an injury like this, or indeed a foot ulcer that is painless, that's a big giveaway. And indeed, if they've got a Charcot foot, which is in someone with my skin tone, red, hot, swollen foot that may or may not be painful. Yeah, if people have developed these neuropathic conditions, that's a giveaway that there is some neuropathy here. But of course, there are tests that we can do. But I would argue if somebody's got a big hole in their foot that they don't feel very well, that tells you far more than whether they can feel light touch, like a 10-gram monofilament that is used very commonly in practice, or indeed a vibratory perception. So some people will have access to a neurosthesiometer, and I'll show you that in the coming slides, or you may use 128 hertz tuning fork to determine vibration perception. So here's our 10-gram monofilament. Back in the day, there were lots and lots of these different monofilaments that we used, but we now use a 10-gram monofilament. There's limited benefit to using a range of different um, density monofilaments. 10 gram is absolutely fine. We would hold that for 2 seconds so that it buckles, and we know it's applying exactly 10 grams of pressure. There are multiple sites that can be tested. You'll see in International Working Group on the Diabetic Foot, they'll talk about 3 sites, the hallux, the first and the fifth metatarsal head area. But actually, when we're doing a screen for everyone, it's useful to use those 10 sites so that we can think back to those dermatomes that I asked you to review, because that will give us a much better picture of which nerves might be affected. Because, as I say, not all neuropathy is diabetes related, and some people won't necessarily have a monofilament on them. So there's another test called the touch the toes test, which is light touch with a finger that could be maybe useful in an environment if you don't have some of this equipment. The neurosthesiometer is on the screen here. It demonstrates the machine itself. You could use a tuning fork. The advantages to this machine are that it ramps up, so you can turn it all the way up to 50 volts vibration, and then we can quantify that value. So anything, if somebody's not feeling 25 or more volts of vibration, then that would be diagnostic of diabetic peripheral neuropathy or a loss of sensation. But you might want to use 128 hertz tuning fork if that's something that you have available to you instead. Or you might have, there are other devices out there like a VibraTip, which is a little pocket device that vibrates that you might use, because this is quite a large piece of machinery. That's thinking about some of the tests we do, but actually some of these require our eyes as well. So you can see on the screen, I've talked about neuropathy. This is the classic intrinsic minus foot. So that is somebody that had some motor neuropathy, so some loss of the nerves that lead to innervate, to allow muscles to function. If they're not working very well, you'll lose the muscle actual mass. So you end up with the foot hands as well, where you can see wasting of the intrinsic muscles, classically this hollow in between the thumb. Here you might see quite hollow, bony hands and feet. Some people might have a high arch like you've got here with clawed toes, because those intrinsic small muscles are not working, so they're no longer able to keep the toes straight. They might have a bunion, which is HAV, hallux abductor valgus. But we've got to remember that people can develop bunions and claw toes for lots of reasons, and might well be something that they've developed as a child. So it's not always a sign of motor neuropathy. It's just something that we look for when we're assessing somebody clinically. Patella test, patella reflexes, ankle reflexes, Babinski reflexes are really important here. So you would use a tendon hammer for that, which again is a fairly large tendon hammer if you've not seen one, but it's a really useful piece of equipment to have in your toolbox. The Babinski reflex is this one that you can see where you're using the back of a patella hammer. Some people use a pen as well to stimulate the sole of the foot from the lateral heel up towards the big toe. And a normal response would be downward going, so the foot would plantarflex, and an abnormal would be upgoing, so dorsiflex with some flaring, some splaying of those toes, fanning of those toes. And this shows us if there is a central nervous system disorder. And I've listed a few potentials here that's something to be important and important considerations. So it could be a amyotrophic lateral sclerosis, could be a brain tumor or injury, could be meningitis, multiple sclerosis, spinal cord injuries, defects and tumors, or after a stroke, you might get an upward Babinski response. Thinking, I've called these ankle knee jerks, they're the common terms. An Achilles reflex is at the ankle, and that tests the S1 nerve. So again, you're just having somebody sit over the end of a plinth, hammering lightly. You're not trying to injure someone here. You're not trying to hammer in a nail. You're lightly touching that Achilles tendon to see if you get a normal plantar response, plantar flexion. You can do the same thing at the patella, and that tests the L4 nerve. So again, with the knee bent, sitting to one side so you don't get a kick, and then lightly tapping the patella tendon to see if that nerve is intact. And a normal response would be the foot, the knee extending, so the foot kicking up. So it's a good thing not to have that person's leg between your legs as you do this. I sit with my legs to the side. Autonomic neuropathy. Again, it's important that we know how to assess this. And I've got a really classic, dry, autonomic neuropathic foot here with these heel fissures because the skin can be quite dry if the autonomic nerves that control the sweat glands are not working very well. But actually, people can get dry skin for lots of reasons. So these are signs, but you need this to be part of a wider assessment. I use an A, B, C, D, E, F mnemonic. I think this is quite useful. So A for autonomic neuropathy is B, bounding pulses, C, cracked heels, D, distended veins, E, erythema or flushing, and F, fat pad atrophy. So when somebody's autonomic nerves are not functioning so well, sometimes you can get shunting from the arterial to the venous tree, and it doesn't necessarily perfuse the skin in the way that we'd like. So that's why you can get these bounding pulses. And when you feel a pulse, and we'll all be very confident, hopefully, in feeling pulses, it feels like your hands are being pushed off the skin surface. A bounding pulse is really very strong and it feels unusual. And it might be a sign of autonomic neuropathy. But again, those autonomic sympathetic nerves that control sweat glands, if they're not working well, the skin will be dry. The skin might be flushed. You might see distended veins again because of this poor tone and poor control. And so this is something also to be aware of. We do have a test that looks at sweating, which is called, there's a Neuropad, which is a pseudomotor dysfunction test. And what you can do is you can pop this strip, it looks a bit like a plaster, that you pop onto the skin surface and it changes color when it reacts with sweat. And that might be another test that you choose to use that's not painful, but just gives you something a little bit more quantifiable in terms of, is this person having an abnormal lack of sweat? And finally, we're going to talk about the management of neuropathic pain, which is complex. The first thing, and I've popped this in this flowchart in for you in terms of how we go about deciding what we're going to do, education is the first thing. So the first question I would always ask before I even consider if medications are appropriate is I would ask about glycemic control if they have diabetes, because we know if somebody's blood sugars are erratic, it's not so much if they're always high, but if they're going high and low and they're really not very stable, that irritates the nerves. And so any drug that we add in is unlikely to work. So we need to look at glycemic control. And there's a really important educational piece here around making sure that somebody knows that they need to get their blood sugars into tighter control for this neuropathic pain to be reduced. And we can't promise that we will permanently and eradicate all neuropathic pain. So there's some expectation management here as well. Eventually, with diabetes, the nerves eventually die and the pain will subside. And that might be a useful thing to say to patients, that there is an end in sight. But I would always ask the question, is the pain or discomfort something that you would consider taking a medication to help with? And quite regularly, people say no, they wouldn't. And then you wouldn't discuss pain medicines if they really didn't want to consider another pain medicine, because people, particularly someone with type 2 diabetes, is usually taking quite a lot of medications as it is. You might talk about some simple analgesia, and there's topical approaches as well. So things like capsaicin, which has the active ingredient in hot chili peppers in it. So you're just giving somebody a lot. You're basically flooding the system with so much sensation that their brain is able to tune it out a little bit better. And there are some of these non-pharmacological options. Actually, talking and having a good conversation is also a really useful part of this. Typically, when we add in, if we do decide that a medication is appropriate, we would add in a tricyclic antidepressant, amitriptyline. And I'll talk about that in my final slide. This is important because this is the first drug and we titrate it. So we usually start at quite a low dose and we would increase that dose until one of two things happen. Ideally, that person no longer has pain, and then we can manage that with a suitable dose of amitriptyline, or they might get side effects, and that's what I'll talk about in the final slide. And if they're getting side effects, then you can't keep on increasing the dose, and you might need to add a second agent in. And this is where it really needs to be within your, well, all of this needs to be within your area of confidence, competence, and scope. Considering, are you an independent prescriber, for example, or should this be better managed in a multidisciplinary team? And there are different ways that this is managed, because some of these other agents, like the anti-epileptic drugs like gabapentin, and I've included an anticonvulsant drug, pregabalin, as well, but gabapentin does have a street value and is potentially associated with addiction. So you've got to be careful about people that are maybe asking for drugs by name, particularly gabapentin. And then these are the seem to be the next line. But then some people do need opioids. And if they're asking for drugs, opioids like tramadol, fentanyl patches, these can be oromorph, these can be really useful for controlling pain. But again, just thinking about the potential for addiction and just being really cautious that sometimes people might, if they're asking for these drugs by name, you've got to be wary and cautious that there might be an addiction or there might be the street value that is driving that conversation. So again, I would suggest these conversations are much better in a multidisciplinary environment. But let's talk about amitriptyline because it's common. It is quite an old antidepressant, but it is quite commonly used in this case. And again, around patient education is people understanding that it is an antidepressant, but that's not why they're taking it. They're taking it to try to help with their pain rather than an antidepressant. But some people are on antidepressants, and you might need to think about the antidepressant they're on and whether it might be realistic or best to discuss with their GP if another change might be more appropriate. But there are some what we call anticholinergic side effects associated with amitriptyline, this particular class of drugs. And here's a bit of a reminder about what they are. People talk about being blind as a bat, so they might have dilated pupils and they might have some photosensitivity. Red as a beet, they might be vasodilated and flushed. Hot as a hair, they might experience hypothermia. Dry as a bone, they might get dry skin from taking these drugs. Mad as a hatter, not, it's unfortunate, but some people do get hallucinations or agitation. Bloated as a toad, some people get iliac or ileus or urinary retention, and the heart runs alone. So some people do experience a racing heart rate, tachycardia. So I do hope that this session was really useful for you in terms of thinking about the assessment, some of the investigations, and the management of neuropathic pain. Thank you very much.